speaker, we work closely with Dr. Choo quite a bit. We really love the things that he does for our patients. And, you know, we have several years have depended on them as kind of part of our team, as part of our practice. So we're very grateful that he could come and speak with us for us today at our conference. But you know, he does a lot of work trying to create solutions for the opioid crisis that we have. You know, we're a very conservative practice, and so we really monitor and try to do anything and everything that we can to not contribute to that crisis. And I think Dr. Hope discovered that some in his talk. But you know, they take really good care of the patients that we send them. We're very appreciative. So if you guys can just give Dr. Choo a warm welcome, we'll go ahead and get him started.
I recognize most everyone here, so it's really good to be out in public and talking again, and it feels a little bit more normal. Just to interact with human beings once more, so I'm glad that you guys are here. So I kind of changed the title a little bit about because of neuromodulation. I'm really trying to also cater to you guys and make sure that you have a good sketch of what neuromodulation is all about, how it may apply to workman's compensation patient. So maybe a little historical context will help. What's going on with today's technologies and how that's relevant to you guys, and what you may see in the future for some of your patients as the technology has evolved. But so let's start with the timeline of neuromodulation and what it is, how it all started, and where we have kind of evolved to today. And when we're talking about spinal cord stimulation or all of these ways of modulating the nervous system, some of the first historical references came through the ancient past, where some of these doctors would use electricity through living marine animals to try to cure some ailments, including the ancient Greeks that used this fish in particular, the torpedo fish, in crazy, crazy ways to help with migraines and gout and some other maladies. And when I'm thinking of this type of treatment, I can't imagine trying to get this past the adjusters. I don't think it would. I don't think they would go for it, no matter how many therapies, physical therapy and MRIs that we get. But it was used, and it's well documented that some of these therapies, I don't know how well they work, but they at least try them. But then you have to kind of fast forward to the 1800s when Robert Bartholomew was the first individual to kind of use electricity. And this didn't come out as I wanted it to, but he had an Irish patient who had an infection that eroded into the skin, through the skull. There was an exposed brain that was easily accessible, and so he tried to mechanically manipulate the brain, and nothing would happen. But then he had the right idea of using a Faraday current and stick the electricity into the brain, and then he realized that parts of the body would contract and squeeze down. So he gave credence to this idea that maybe electrical impulses somehow affected the brain. 10 years later, Victor Horsley was the first individual to actually apply the same types of current into different parts of the cortical structures of the brain to kind of map out the brain electrically. And then really it turned into, we have to turn the clock to 1957 when Dr. Earl Backen, who was the founder of Medtronics, was the first man to invent and implant the pacemaker. And so, piggybacking off of this technology, Medtronic then started using this technology for deep brain stimulation, spinal cord stimulation, and Norman Shealy was the first gentleman to implant a spinal cord stimulator device using that same type of technology. But really, the development of the technologies improved in the late 1990s, early 2000s, where it became more conventional therapy, especially in the pain field and neurosurgical fields. And so this is an older stimulation unit with 4 contacts that was kind of the original devices that were made mainstream to physicians during this time. And this is the type of stimulation that really was kind of grew the field. It's the stimulation that is used when you actually feel vibration and tingling down the low back into the legs. And this conventional stimulation was used for many, many years. But today, as time has gone on, we've had a lot of competing devices. Medtronic was the leader in the field. But then you had a lot of other device makers, Nebra, Boston Scientific, Abbott. These are probably the four leaders in the field right now, using this technology and expanding upon it now. So especially in the past 5 years, neuromodulation stimulation has changed completely and revolutionized the way that we take a look at patients, how we treat them. We would use stimulation kind of towards the end of pain treatment, and now with evidence-based approaches, we realize that the sooner that we use stimulation, especially when back surgeries have not gone well for patients, or complex regional pain syndrome, so some of these peripheral nerve problems start creeping in, it's better to use these therapies earlier rather than later so that we can avoid opioids. It turns out that patients seem to function better when you use neuromodulation earlier on rather than placing them on opioids and trying to wean them off. So really, it used to be, as the technologies have improved, we push this more on the front end of treatment rather than at the very end. And so when you guys are thinking about when should we have these conversations about neuromodulation, when you're having a patient that's struggling with nerve-related pain as a result of back surgeries or an operation that has not gone right, or just a really, really traumatic injury, really have this on the forefront of your mind as something that should be done sooner rather than later, if there are no more operations to be done to fix the patient. So neuromodulation is a really large term, okay? So neuromodulation can really is, I guess you could define it by saying that you can stimulate any portions of the nervous system, including the brain, the peripheral nerves, the nerves in the spinal cord. This is not as relevant to the work and compensation realm, but deep brain stimulation is really being used a lot in certain areas, especially for movement disorders like Parkinson's, some kind of Tourette's as well, where they place these electric probes in very specific areas of the brain in order to help with these movement disorders. This is just kind of an X-ray showing this very precise placement of these leads into certain portions of the brain in order to help with patients who are really struggling with neurological issues. And so another way of modulating the nervous system, when I think about it that way, is not just through electricity, but you can use chemicals, right? So medicines, pharmaceuticals. And so another form of neuromodulation is through intrathecal pumps. So you can place a piece of tubing essentially into the cerebral spinous fluid and leak different types of pharmaceuticals near certain nerve structures in the spine and in the neck in order to help with certain painful conditions or spasticity, end-of-life care. And by really concentrating the medicines near the certain portions of the spine, you can use very, very small concentrations and potentially have less side effects as a result, systemic side effects. And so really in the early stages, in the late 1990s, early 2000s, intrathecal pumps were used a lot. But it was kind of like a lot of pain treatment during those times. It was kind of the wild, wild west where there were a lot of doctors were just throwing all types of medicines into this cerebral spinous fluid, trying all different types of combinations of medicines. The evidence-based approaches weren't quite there yet. It's really kind of the time of experimentation. And some of that was good, some of that was not so good. But as time has gone on, there's been a lot of refinement in what's the best approaches for things like intrathecal pumps. And so here's another X-ray version of intrathecal pump treatment where you can see that there's a subcutaneous placement of this piece of tubing that goes straight into the spine, and you can see it kind of here that it lands somewhere right next to the spinal cord itself. One of the first meds to be used is opioids. So during the late 1990s, early 2000s, that's kind of right around the wrong time of the thought of the fifth vital sign and using opioids left and right. That also translated into intrathecal opioids. And so there were doctors that were driving these opioids super, super high into the intrathecal spine. Once you got to a certain kind of higher doses, granulomas could form around the actual tubing and cause all types of problems. And so as knowledge started to, and experience started to unfold, we realized that less is more when it comes to intrathecal dosing, especially when it comes to opioids. And so really the doses are much lower than they used to be. You try to wean patients completely off of oral medications, especially if you've got intrathecal delivery of opioids. Snail toxins, actually, you can use Ziconotide as a derivative of a particular snail toxin that can be used for neuropathic pain. I've seen absolute miracles with spasticity. So if a patient has a stroke, neurological injury, spinal cord injury, and a lot of spasticity as a result of those particular injuries, cerebral palsy, some of these contractures can be really, really painful. And also, patients can be so contracted that they can't move their limbs anymore. And that means they can't function with their arms, they can't walk. Using baclofen intrathecally can be an absolute godsend where you can finally, patients go from a contracted posture to actually being able to relax their muscles. They don't hurt as much. They can actually control their limb movements a lot better. It can be an amazing therapy for some patients. And really, in end-of-life care, terminal cancer, intrathecal pumps have a really good role for compassionate end-of-life care. Peripheral nerve stimulation is another type of stimulation. Instead of targeting nerves in the brain or the spinal cord itself, you can actually target particular nerves outside of the central nervous system. One of the more common ways of doing it is to target occipital nerves. There's not a lot of coverage in workman's comp for this type of care, so I would be shocked if any workman's compensation carrier would approve peripheral nerve stimulation in 2020. But for some exotic headache problems, occipital nerve stimulation can be helpful. Sometimes you can throw leads into the front of the face for certain types of facial pain or pains or headaches. You can actually use peripheral nerve stimulation for targeting different nerves like the femoral nerve or other nerves that have been injured before in the past. So that's more of an academic type of approach. You're not going to see that in a standalone practices because insurances and workman's compensation simply don't pay for those types of treatments. So you're not going to see it very often. But these are nicely placed leads near the occipital nerve that can really help with some patients and their headaches. But for the workman's compensation population, so how does stimulation really fit into your all's world? When you're talking about injured patients, the most common reason for me to actually start using spinal cord stimulation is for patients who've had neck injuries or low back injuries that had one surgery and the surgeons have said there's no more operations to be done, but they continue to have neck, arm pain, or if they've had a back injury, they continue to have low back pain and pain that sits down the leg. And really, there's no fix anymore. The nerves have healed as much as they can, but they still have ongoing pain and misery. Post-laminectomy pain syndrome is probably the most common reason for us to start thinking about spinal cord stimulation. So if you've had a patient that is 6 months out of their operation, and your neurosurgeon or ortho spine surgeon has said, hey, there's nothing more to be done. Instead of opioids, you might want to consider sending them to an interventional pain physician that might have the abilities to do something like spinal cord stimulation earlier rather than later. Another condition, I've done a talk about complex regional pain syndrome before for workman's compensation audience. And also, it's a type of neuropathic pain, other nerve-related injuries. Complex regional pain syndrome is a very specific neuropathic pain condition. But there are other nerves that have been injured and trapped, phantom limbs, things like that, that spinal cord stimulation can be very, very helpful. Complex regional pain syndrome in particular is a dramatic disease. So someone has had a crush injury or even a pretty benign injury or a simple operation, and the surgeon is scratching his or her head saying there's really, the pain is kind of out of proportion to the surgery or the injury, but there's some clear evidence that there's something going on where you see swelling and skin color changes, and the mottled coloring of the skin, the skin may even turn purple or blue or red. It's very sensitive to the touch. There's clearly something wrong, and you really have to have objective evidence of some of the of complex regional pain syndrome. There are clinical criteria that are out there that are objective, but when the surgeon has said that there's really nothing else to be done, you might be thinking that these neuropathic pain syndromes, especially if you've got some physical evidence that there's something clearly not right with the limb. And CRPS is something to think about. There are some physical therapies that are specific for CRPS, but sometimes those don't really help or as much as you would like for them to. So when they start 6 months down the road, they've done everything else that they can possibly do for this particular pain, start thinking about spinal cord stimulation as a treatment. And so this is a pretty clear problem, especially when you compare it to the unaffected limb. But someone with CRPS can present very much like this, where there's swelling, and you would think that there's an organic problem, there's a fracture, but a lot of those things, it's fractures and other organic reasons to have this type of presentation that are easily seen on X-ray or MRI are just not seen. CRPS is one of the first things that come to mind, especially with the injured patient. With spinal cord stimulation, there's a lot of different types of leads now. And so you saw the 4 contacts with the earlier conventional stimulations out there. A lot of them come with 8 electrodes, some come with 16. These are paddle leads that are surgically implanted by neurosurgeons. I don't implant these, that's what our neurosurgical colleagues and orthospine colleagues do, but we will implant these smaller percutaneous leads. We usually trial our patients with these types of leads prior to any type of implantation. But when you're working out the patient, okay, so really the first things I think about are has my patient had an operation in neck or lower back? Is there more operations to be done? If not, I think we've exhausted conservative therapies, okay? And if all of those, we check mark off the boxes on all of those parameters, we really start thinking about using spinal cord stimulation. And the first step is to send them to our psychologist. We have 3 in our office, 2 of them which do these very specific testing for devices. But we have to have that clearance. Your workman's compensation will all require a psychological clearance. So expect that as part of the workup. We're trying to eliminate unreasonable expectations for patients. We're trying to see if they have any kind of measures or marks for that would preclude patients from good outcomes, especially pain catastrophizing. If they are really not doing well with their pain, so to speak, there's some psychological measures to look at that. They may need some interventions prior to something like a spinal cord stimulator. And so a multidisciplinary pain practice may have some of those resources in order to help with those things. And there's some other, we don't want patients that have really bad delusions, really sick psychologically, because they will not do well with stimulation. So a lot of those psychological parameters have to be screened out prior to approval, and workman's compensation will require that for all stim patients. And then there's a trial. So we don't just put a stimulator in a patient and say, have a nice day. We've got to make sure that they respond well. So after the psychological clearance, we'll place two leads, traditionally speaking, for these patients, especially for the low back patients or neck patients, or complex regional pain severe patients. Usually have one or two leads, primarily two leads. And it doesn't take long. This is an epidural placement of these wires, and so that's very much the same type of epidural placement for women who are about to deliver a baby. It's a little bit more sophisticated. You get to use an X-ray fluoroscopy in order to help guide our lead placement, because we don't just leave it in the same places that we would leave epidurals for pregnancy. We actually place it a little bit higher, especially in the low back. We might put it at thoracic level 8 or so, higher up for the cervical, our cervical patients, in kind of the C5, C4 level. Just kind of depends on how much coverage you get in those particular areas. But regardless, we have we place these leads in a way where they will stimulate some of those pathways that lead up from those damaged nerves, maybe in the low back, that shoot up the spinal cord to the brain. Okay, and so basically, what you're doing with these contacts is stimulating the spinal cord in a way to either with conventional stimulation replace some of those painful feelings with a nice vibration feeling. But now with the newer technologies, there are all different ways of stimulating the spinal cord. A lot of it has patients do not feel stimulation anymore. The newer technologies in the past 5 years or so are almost all are what we call paresthesia-free devices. So you may have had old stim patients that had this therapy, and they kind of have that fall in love with it at first, and then after a year or two, the thing just doesn't work as well. They're really kind of annoyed by the therapy, where in order to get that coverage, they have to move in a certain spot, and then they get to get it to start working. Or if they move in a certain spot, they get a zap down their leg or across their back. It's really uncomfortable. And there are a lot of reasons why those things, that type of stimulation was, one, helpful, and over time not so helpful. And a lot of it has to do with how, as you breathe, these leads will move, and sometimes they get a little bit too close to the spinal cord, and so if they take a deep breath or cough, they'll get a zap down the leg. And so that became rather annoying for a lot of patients. Now with these paresthesia-free devices, you just kind of leave it on. It's sub-perceptive, so you can't really even feel it to begin with. You don't have to think about it. Back in the day, you'd have to turn this thing up and down like a volume to a TV in order to get the right feeling. It's not too low, it's not too much. And sometimes you would be stimulating in a way that was subtherapeutic, but if you drove it up to the therapeutic range and you coughed, and it got to the point where it was just uncomfortable. But now with these paresthesia-free devices, you just leave it on and you don't have to think about it. And so as far as the trial to permanent ratios now are much more improved. So a lot of patients are moving on to the full implantation because they just simply like leaving it on and not having to think about it. And so this is an X-ray of a lead that's placed in the thoracic region, and then another X-ray of a nicely placed lead right here for a cervical patient. You can clearly see that this patient had an operation prior to placing the spinal cord stimulator leads in the cervical region. And so these are trial leads. This is actually an old trial lead. Now, they're a lot more, they're a lot smaller now, so you don't have to wear these cumbersome kind of units anymore. But this is a trial lead. You leave these leads in for about 6 to 7 days. You see if the patient gets a lot better with these temporary wires. And so this is another form of the same type of thing. These trial leads are left in 6 to 7 days. They walk around with their life. We want them to do as much as they can during that time to live as normal of a day as possible. The last thing that we want to do is have a patient come in, get the trial leads, sit on the couch all day long, and they say that they feel a lot better. Well, that's probably more of a function of not doing anything rather than the actual leads doing something. So we actually encourage the patients to move around. And again, this is the epidural placement right next to the spinal cord. These contacts are sending impulses to the spinal cord, and actually some of them are stimulating the brain itself. We're realizing with some of the newer technologies that the brain is being stimulated. So at the end of the trial, we have a frank conversation about how this has gone for them. Is this something that has really worked for them? And it's got to be very clear to me, okay, that this patient has had an exceptional week, all right? And so the benchmark cutoff is 50% pain relief or better, okay? But really, in the end, it's, I can tell whether or not the patient has done really well because they're smiling at the end of it. They're telling me, please don't take this thing out. I've got to leave this thing, and this is the best I've felt in many, many years. It's got to be an overwhelming, almost clinical sense that this patient has done exceptionally well, beyond just the number of 50%. There are some patients that are so desperate for pain care or pain relief that they may be on the fence and they say, well, it was okay. I still got about 50% relief, and I've seen with the representatives that have worked with it during the trial that this patient has come in 3 or 4 times for adjustments, and they're just not really getting the relief, and it's not that kind of home run. Even if they tell me the right words, 50% or more, I'll tell them not to do it. If they not move on to the full implant. A lot of times it's that type of sense that you get that the patient is really just wanting some relief, but inevitably if you implant a patient like that, they've been in and out of your office for a trial for 3 to 4 times. That's going to be the projection of the future of how they're going to do with that full implant. That they're just going to keep on coming back and trying to find the right setting. It's not really working. And then after you've implanted a patient like that, you have to explant them, and you have a conversation. Well, what happened? And they're like, no, it was just okay. That trial was I just wanted some relief. And they just made the wrong decision for themselves. So really, in the end, it's a frank conversation with the patient. You're not doing really, really, really well with this trial. It's not been anything but fantastic for you. Don't do it. Okay? Don't do it. It's just going to be a waste of your time. But the really great thing about stimulation and new technologies today is that if you have those upfront conversations prior to even sending them to the psychologist, and you really are fleshing out for really reasonable expectations, reasonable patients, those patients that are compliant. Dr. Hovis was talking about smoking and diabetes as benchmarks for whether or not a patient will do well with some of these operations. It's the same thing with spinal cord stimulation. If you have a smoker or diabetes that are out of control, their outcomes will not be as good. So if I am doing my due diligence as a clinician, I'm going to make sure that our patient sugars are under well control if they've got diabetes. And I hold my patients' feet to the fire and make sure that they're below 7.0 on their hemoglobin A1C. And I'll wait for that patient for months for them to work on it. It's better for the patient. They've got a lot more skin in the game because they've really worked at it. They're showing some compliance. They've jumped above the bar, so to speak, and the outcomes are way better. Also, there's frank conversations about how their trials should be. Now, if you do all of those things, your outcomes can be northward from 80% of your patients doing well with these trials and moving on to full implantation. We don't ever expect 100%, but anywhere from 80, the traditional conventional stimulation would hover around 60 to 70%. Now with these newer technologies, you're northward of 80% or so. But you really, as a physician, have got to do your due diligence to make sure that these patients really fit the actual clinical criteria for the trial. They've got to give expectations. So implantation, if they do well, move on to the full implant. It's about an hour, a little less than an hour to do the full implantation. They go home the same day, so this is usually not as big of an operation as what they've already experienced before. It takes about 6 to 8 weeks for everything to heal, and this is just kind of a cartoon of where we implant this generator, which is usually right above the iliac crest. the lumbar spine, so they're not really kind of sitting on it. Actually, I actually put mine a little bit lower, below the iliac crest, so that they can put their hands above the incision line. These devices can last 5+ years. Some will last upwards to 10 years. Some are rechargeable, some are not. I've been moving more towards the non-rechargeable units. It's just a lot easier for patients to use. I've moved explanted old rechargeable units and reimplanted non-rechargeables, and patients seem to like that a lot more. It's one less thing to think about. Another X-ray of someone who's had previous back surgery and implantation with some epidural leads. And so what are the other new ways of stimulating? And I think for workman's compensation, this is another technology that has been out for the past 4 or 5 years that have really revolutionized the way that we treat some of our orthopedic spine, ortho patients, not spine patients. And so if you've had a patient that's had a knee replacement and they continue to have pain, there's a certain percentage of patients that will continue to have pain even after the best operation is going. And so if they're really struggling with their pain afterwards, and there may be a hint of a neuropathic component to their pain, maybe CRPS or something like that. Another area where I use this quite often is those ankle injuries. And so they've had 1, 2, 4 operations on their ankle, and they continue to have a lot of swelling and tenderness and neuropathic issues. This new form of neuromodulation stimulation has really changed the game on how we treat some of our patients. And if you start seeing something like this person might have had just an ankle injury, and their leg swells up, and their knee swells up, and their entire affected limb looks quite different. Instead of stimulating the spinal cord or the central nervous system in terms of the spinal cord itself, there is the dorsal root ganglia that lives right next to, just outside of the reach of the spinal cord itself as it exits the foramen. This ganglia, this is not a very good rendition, but is responsible for these dermatomal patterns of pain. Okay, so if this is the L3, which you can't really see, it may have responsibility of pain into the knee itself. And so, say we have a patient, and so this has been measure of where some of these pain, the actual dorsal root ganglion will have some kind of responsibility for certain parts of the limbs, right? So L1, L2, L3, L4, L5, and S1. And so instead of stimulating the entire spinal cord at the thoracic 8 level, what I might do is just target the one particular area that might be hurting. So what I've seen in a lot of patients who've had multiple knee surgeries, they've had one replacement, that's continued to hurt quite a bit, is that I will stimulate the L3 nerve root. And there's an actual different type of lead that we use, and I'll show it to you here in a second. We place it right at the foramen, not at the thoracic 8 level anymore, and I just stimulate that nerve in a way, that dorsal root ganglia, and in order to target this particular area of the body. Someone who's had ankle pain, they've had multiple operations in their ankle. What I'll do is I'll stimulate 4 and 5. Someone that's had a lot of foot operations, crush injuries, something like that, multiple foot injuries, L5S1. Even the rare occasions you've got a pelvic fracture, someone's gotten into a major car accident, and they've had multiple hip surgeries, pins, and all this kind of stuff, and maybe a replacement, who knows. L1, you can target those particular nerves too, and it's been an absolute godsend for a lot of these patients. They know normally what we do is put a lead up in T8 and hope for the best, but with this targeted therapy, you're actually targeting these teeny tiny dorsal ganglion nerves. You can just stimulate what the particular pathway that's bothering them, and this is also a paresthesia-free device, so they do not feel the stimulation. The pain just kind of goes away. All right, so we've had some patients that have had operations on their knees 3 or 4 times with skin grafts as a result of particular injuries. Life changing for these individuals. You can go back to their 10 to 12-hour jobs. a day, and then go back to their recreations, hunting, all that kind of stuff. So we've seen some great things that have come out with it. So here's a good cartoon of this lead that is hanging out with the foramina, right next to the actual dorsal root ganglion itself. The placement is a lot more delicate in a lot of ways than some of the spinal cord stimulation placement in the thoracic and cervical region. There's a lot more maneuvering with the leads. It's a completely different technique altogether. And if you are to highlight that, the actual anchoring is internal in the epidural space. So we thread this catheter into the through the actual foramina itself here and here. So this is a 4, and this is a 5 stimulation. So this would be for someone who's had an ankle injury of some sort. And if you can see, these are these internal anchors here. So you actually thread the wires in this kind of S-shaped configuration to internally anchor within the actual epidural space itself. And there's particular techniques that we use for that. All subcutaneous is still accessing the epidural space like you would for a pregnant woman. The devices that we use are a little bit different. Placing 2 leads like that for a trial, it doesn't take all that long if you're skilled, but you still trial it in the same way. They get 6-7 days with these temporary leads in. They've got to have fantastic relief afterwards. But, so this is a great therapy for a lot of your ortho patients who've had fractures in their lower extremities and they continue to hurt quite a bit. So in the future, what does neuromodulation look like? With neuromodulation, now there are different types of stimulation kind of theories that are out there. Some lateralizing the leads off to the side to do some nerve root stimulation and putting them on different types of frequencies. Boston Scientific has used these 16 contact leads on each side to help with certain kind of lower extremity problems. And then now, instead of actually stimulating the nerves and stimulating the peripheral nerves, there are some thoughts that you can actually stimulate these microglia. So there are some support structures in the nervous system. So instead of just stimulating this nerve, there are thoughts to stimulate the microglia. There are some units that are out there to this day that report that microglia cell stimulation is working just as well as conventional nerve stimulation or spinal cord stimulation. Actually better with rates as high as 80% relatively for trial issues. So, and it's also a subperceptive paresthesia-free type of device as well. And ECAPS is something that might be coming down in the future. It's low compound action potentials. This is closed loop system. So what that means is that, so if you stimulate here in the bottom portion of the leads and you're sending electrical impulses up to the brain, this part of the lead will sense how much stimulation is actually going into the spinal cord itself and make adjustments. So instead of just having one type of frequency and input that are going to the spine at all times, the problem with that is what we were talking about before with some of these old conventional stimulations with cough, some mood, you feel a zap down the leg, you kind of uncomfortable, you drive it down, it would be in subtherapeutic range, you drive it back up, it's too much. Where with this closed loop system, as it's sensing exactly what's going through the frequencies that are going into the actual spinal cord, it will adjust. So if you cough, it'll make a quick adjustment to the spinal cord so you don't feel that zap anymore, so you're getting a much smoother type of care. And apparently the outcomes are pretty exciting for this type of treatment. And there's some other types of stimulation. There's some play with this medial branch stimulation. Activate is the name of the system. A lot of these smaller companies, they go out and they innovate in hopes of being snapped up by a big corporation like Medtronic and make their millions and millions of dollars. But so this is a placement outside of the spinal cord altogether. It's still neuromodulation because you're stimulating these smaller nerves. And this is for facet pain, low axial back pain as a result of arthritis in the back. So we'll see how that works. A lot of these things are out in the kind of theoretical world, a lot of trials that are going on, and hopefully will be released pretty soon if the outcomes look great. That's about it. So I'm open for any questions that you have.
Question?
Yes.
Prior to me taking, I worked for a neurosurgeon, and we did all the Medtronic stuff.
Yeah.
We did the psych review. We love the back of 10 times because it's miraculous to see that. We didn't do it wasn't baclofen, if it wasn't cancer, we didn't implant the time. And then the right patient, stimulation, we had excellent results. But you have to really weed through a lot of different people. And so I think it's really fascinating to see the change. So when you do after you've got a permanent implantation, do they have a unit at all, a remote that they're increasing or decreasing, or that they can make some changes?
Yeah, there are still ways for the patient to have controls, even with the sub-perceptive paresthesia-free devices. There are different settings that they can use. So really one thing I didn't touch upon with my talk here is the relationships that the clinicians have with their reps. There is a lot of evidence that ongoing relationship with your reps, your ongoing relationship with your patients too. One of the things that you can fall into a trap is that you put the device in and let your patients go and say goodbye and never see you again. Just call me when you need. But really, some of the better practices that are out there will check in on the patient, make sure that 6 months down the road that you kind of sit down with them every once in a while and say, hey, how are you doing? Oftentimes, if you just kind of forget about these patients, they'll make some change or forget how to use a certain setting or whatever it may be. And oftentimes you can veer off, stave off problems, so to speak, by addressing those kind of proactively with each and every one of your patients that you stimulated or placed an implant on. And those small micro changes that you might make or kind of reminders will improve your long-term outcomes. But you have to have a responsive team. So these devices can all be great, but if you don't have a good set of reps that you've had good relationships with for a long time that care about making those phone calls, checking on the patients, because you still have to maintain that type of relationship with the patient. So those reps are invaluable. So no matter how good the devices are, if you kind of just leave patients to their own, you're still going to come back with unsatisfied patients, and they will be really unsatisfied if you don't have reps that are there to kind of help you manage all of that stuff. And so some of the better practices that are out there will help develop that relationship and make sure that you've got the right people in place in order to manage all that stuff. Because they're not going to be part of the clinic, they're going to be part of the actual device team.
So for the failed back syndrome arachnoiditis, you do a Peripheral trial, and then you do a permanent implantation. But for the extremity injury, you would use the threaded percutaneous.
Yeah.
And then would you just leave it there permanently?
Yeah, it depends on the issue, but mostly you could kind of think about it in that way where failed backs, no one likes to call them failed backs, so they call them Laminectomy pain syndrome. Yeah, the perc leads into this near the thoracic level or the cervical level, depending on where you have your operations, is your go-to. I love doing these DRG lead placements, but the problem is a lot of the insurance companies are still not on board with DRG, even though it is very clear with the data that in comparison to conventional stimulation, DRG is far superior for these extremity local neuropathic pain problems as a result of these lower extremity issues. And so that's my go-to, but they might have already had an operation too in their lower back. So your pathways in order to actually place these leads are blocked, so to speak, because of the previous injury, so you would just use a percutaneous lead. So really the way the neuromodulation is done now is that you've got to kind of fit the right condition now with the variety of different tools that you have. Back in the day, it was just kind of one or two systems, maybe three systems, and they all kind of did the same thing. Now there's so much variety in how you use it. It's made it feel more exciting opportunities for patients.
But do you leave, like if you're doing something for an ankle, you just do a trial with a perk lead and then just leave that lead in. But you're not going to weave a surgical paddle into that. Right?
No, so the way that would work is that it's all percutaneous for DRG. So after the trial, we remove those leads anyway, no matter what. You just go back in, if they've done well with the trial, go back in, place them the exact same way, vary your leads sub-Q to your generator. So it's great because you're not doing any surgical kind of cut down towards anchoring your leads like you would for your spinal cord stimulator leads. You have special anchors that you would use in the back. You anchor internally with your epidural placement. So those S leads that you saw are your anchors. And so as you place them in the epidural space and you make those S anchors, you do that for the actual permanent implantation as well. So it gives you a little bit of space just in case the patient moves and it pulls on the leads a little bit. They scar in that S formation, and those are your internal anchors. So actual placement is faster a lot of times for full implantation with those DRG leads. It's really great. Yeah.
What have you found the most effective for like lower extremity amputees as far as pain management?
Pain management. I mean, DRG can be great, and also spinal cord stimulation. It's just sometimes it's a little bit more complicated than some patients have stump-related pain, which is a little bit different than just quote unquote carrying one. So you have to. It kind of just depends on the type of chronic pain syndromes that they have as a result of their amputations. But these DRG can be fantastic for phantom limb as well.
Have you found that any topical does, because I've had another experiment that topical compounds do great.
Yeah.
But we're not seeing it with the lower extremities.
Everyone's different, and so if you can get away with it, topical compound cream and with some neuropathic pain, it can be great. You can either using bupivacaine, ketamine, something like that within your topicals. That's fantastic. If that's all you need, you don't need to be having this discussion. But most of the times, by the time they come and see me, it's compound cream. Hasn't been ketamine.
Do you use the methadone for any of your
Methadone as an oral medication for, methadone is usually kind of one of those medications that we use later on in treatment because it does have a lot of complexities when it comes to management because of the potential for heart arrhythmias. But it's a very cheap medication and it has very specific properties that might be more helpful for neuropathic pain. But it does take an experienced use. It's not something that not in this day and age anymore. Primary care physicians aren't doing hardly any opioid management. But it's really kind of not frowned upon, but discouraged for the non-experts to be using methadone. But it can be awesome. It can be great. It can be something that helps those who respond to it.
That's what my information on that he was on that, and that's like looking at, stimulator or maybe topical, that's something.
It'll be difficult though, as there have been abuses with neuromodulation. In other words, there have been some unethical issues with neuromodulation, but back in the bad old days, I guess, there were providers that were placing these leads willy-nilly, and as a result, a lot of the carriers and insurance companies really cracked down on the indications for neuromodulation. And so sometimes with phantom limb, it's very difficult to get the approvals for more competent trial neuromodulation, but it can be very helpful if you can get it passed.
When you do the stimulation
depends on the patient. It's better to try it earlier rather than later. That's why was part of the conversation was to do it before you even think about doing opioids. And I think a lot of carriers are interested in that because there's been a lot of data analysis on how much money will be saved to the carriers over a period of time by doing stimulation earlier rather than later than undergoing opioid treatment. But there are a lot of legacy patients that have been on opioids for a long time. And so the data out on opioid patients is that they have a tendency to not work as well on those patients who have already been on opioids or even gabapentin or another neuroadjuvant. And there's some thought as to why that might be because of the way that stimulation may be blunted as a result of those meds. But with that said, I've had a number of patients come completely off of opioids. They may not be 100% pain-free. That's another thing with neuromodulation expectations is that you never tell them that you're going to be 100% pain-free. But half or more of their pain better. And if you've got the right motivated patient, they'll work themselves off their opioids. If they don't work themselves off their opioids, maybe you've gotten them off of another neuroadjuvant, or they're on less, you cut it in half. That's a one for everyone, I think. They're a lot more clear-headed. And a lot of patients, I think if you approach it with this type of thought of saying, hey, we're going to do the stimulator. And if you do well with this, it's up to you as to how much you want to come off. Most of the patients, if you approach it that way, give them the agency and the control of saying, hey, you can come down as much as you want. Most of them come down. And some come completely off. Occasionally you'll have the ones that say, well, I've got 50% pain, can I have another extra hydrocodone? The answer's always no. 50% better. You want more hydrocodone, there's something not right. But most, if you've done your due diligence, you can get them down.
There was 3 reasons that we typically did pumper stim: backup and pump, which was my favorite part, CRPS, seeing great results, and breathe and fill back. And as technologies change and we have all this fellowship trained spine surgeons, what we saw in our practice was big surgeries, a lot of arachnoiditis, a lot of those kinds of issues, poor technique. Obviously, technique is improved as the training's improved, and you're making smaller incisions, using better hardware and all that. So because of all those technology changes, are you seeing less, post-laminectomy syndrome or arachnoiditis, those things that leak the soft tissue?
I certainly don't see as much arachnoiditis. I don't think. But we have a lot of patients that have operations, and I think this is a direct function of we just don't have a healthy patient population in East Tennessee to begin with. So people have bad backs. So there's no shortage of operations on the lower back here in this region. And so I don't see these major fusions and these big operations. Everything is a little bit smaller, but there's plenty of opportunity to take care of back problems with neuromodulation. That's for sure.
I'm going to ask a question.
Yes.
I know I'm not really. So just out of curiosity, when you do say you use neurostim on an ankle, does that affect their gait, their ability to walk? Is that ever something that considered?
Yeah, I think I've certainly seen it in the knees. Patients standing longer, walking better, especially if it's. I have to be really make sure that the orthopedic team has done everything that they can possibly do. There's everything's been replaced that needs to be replaced. There's nothing that, in their opinion, that needs to change or fixed, right? Because that's a problem that you can run into is that you get an overzealous interventional pain person and they just throw in these things in and lo and behold there's a tendon fix or something else, right? But if that's the case, you can weed all that stuff out and they're hypersensitive, they can't stand on it very long because they throw one of these things in, they're standing on it instead of 1 hour a day. If they're standing out 4 hours a day, that's great. And I've seen patients walk out saying, I can have a normal gait after all this misery that I've experienced. Yeah, there's definitely sure, especially the sleep The sleep is critical. I think that's where you see a lot of neuropathic pain patients really suffer, is that with some of the kind of joint-related issues, a lot of times hurts when they're standing or doing particular activities, but with the neuropathic pain, the pain seems to get worse at night. And so we put these stimulator wires in, especially during the trial, and they said, I slept like a baby all week. You're going to have a good outcome for some of the patients, because then that rest really changes their mood, changes everything. Anything else? Thank you very much.
Thank you, Dr. Choo. Really appreciate that.